أفراد مرضى الثلاسيميا أو أصدقاء مرضى الثلاسيميا أنشئت منذ عام 1990. يعني السنة دي بقى لنا في الجمعية، اكشوالي احنا بنشتغل قبل كده بكتير، بل لكن بدأت كجمعية ونشاط للجمعية من نشاط علمي وسوشيالي وخاص بالمرضى ورعاية المرضى الثلاسيميا منذ يعني رسميا منذ 1990. On the behalf of the Egyptian Association of Thalassemia Egyptian Thalassemia Association, I welcome all of you to attend the 14th international meeting of our society, and welcome our visitor from abroad, especially Professor Abdul. And now we can start by Dr. Maha Murad. She is the head of pediatric department, Cairo University. She will give a talk about our society. Please, Professor Maha, welcoming our dean, Dr. Hussein Khalid.
Good morning. I would like to thank my dear Professor Dr. Amal al-Bishrawi and my dear colleague Professor Dr. Anis Ragab for inviting me to this excellent Thalassemia Day. Our hematology unit is the pride of the pediatric department, and we are always looking up to this very active team, internationally accredited. And of course, I welcome our dear Dean, Professor Dr. Hussein Khairi, and I would like to give the mic to Professor Dennis.
On the occasion of the 14th conference of the International Thalassemia Day, which is held yearly in collaboration between the pediatric department, the hematology clinic of the pediatric department, the Egyptian Red Crescent Organization, the Egyptian Society of Hematology and Research. The conference is yearly an occasion to meet with our dear invited international guests, to exchange expertise, and to have a session together with the patients to discuss their problems, to discuss the international research, which is always held at a very busy and very successful department, which I'm proud to belong to. I wish you all a fruitful conference, and I will not take long talking because we have a lot to look forward to. Thank you very much.
And now the head of the conference and the head of Thalassemia in Egypt, Professor Amal al-Bishrawi.
Welcome all of you. اهلا ومرحبا بكم جميعا. الاستاذ الدكتور حسين خيري عميد طب القاهره، الاستاذه الدكتوره لميس رجب نائب رئيس المؤتمر وعميد الكليه السابق، الاستاذه الدكتوره مها مراد استاذ ورئيس اقسام طب الاطفال بكليه طب القصر العيني، الاستاذه الدكتوره منى التاجي نائب رئيس المؤتمر، الاستاذه الدكتوره نورمين قداح سكرتير عام المؤتمر، الاستاذه الدكتوره الهام يسري نائب سكرتير عام المؤتمر. ابنائي وزملائي والاساتذه الاعزاء، سيداتي وسادتي، في اليوم العالمي لانيميا البحر المتوسط، بالنيابه عن اللجنه المنظمه وعن ابنائنا واحبائنا مرضى انيميا البحر المتوسط وامراض الدم، بتوجه بالشكر الى الاستاذ الدكتور حسين خيري عميد طب القاهرة الذي أعطانا من وقته الثمين هذه اللحظات أو الدقائق ليحضر معنا افتتاح هذا المؤتمر الهام الذي يمثل مرض من الأمراض التي تنتشر في مصر والتي تصيب كثيرا من الأطفال من أطفالنا الأحباء. واليوم رغم مشاغلهم الكثيرة السادة الحضور إن مرض أنيميا البحر المتوسط هو أكثر أمراض الدم الوراثية المزمنة انتشارا في مصر والوطن العربي، حيث تبلغ نسبة حاملي المرض في مصر أكثر من 9%، وهي أعلى نسبة على مستوى العالم أو من أعلى النسب على مستوى العالم. ولما كان هناك عدم البدء في عمل خطة توصية للجنة للحد من انتشار المرض، فيولد سنويا في مصر أكثر من 1000 طفل مريض بأنيميا البحر المتوسط. ذلك يكلف الدولة الكثير ويكلف الأهل كذلك من الأموال غير الجهد النفسي والمعنوي الذي يصيب الأهل ويصيب المريض. وبفضل الرعاية التي تقدمها الجامعات ووزارة الصحة متجلية في التأمين الصحي، والذي يقدم الرعاية الكاملة للمرضى بدءا من العلاج الدوائي إلى زرع الخلايا الأم للطفل المصاب. كذلك مستشفيات جامعة القاهرة مستشفى أبو الريش الأطفالي الجامعي يقدم هذه الخدمة لمرضى أنيميا البحر المتوسط وهو زرع النخاع. فقمنا فعلا بزرع أكثر من 10 حالات ناجحة في زرع النخاع في مستشفى الأطفال جامعة القاهرة تحت رعاية الأستاذة الدكتورة مها مراد. وفضل هذه الرعاية وبجانب الرعاية التي توليها لهم بسبب الجمعية استطاع هؤلاء المرضى أن يواصلوا حياتهم داخل المجتمع، وأصبح منهم الطبيب والمهندس وغيرهم من الأعمال الأخرى. وقد حرصت الجمعية المصرية لأنيميا البحر المتوسط والتي شرفت برئاستها منذ سنة 1990 وبرغم هؤلاء المرضى أن تعلن أننا بالقسم الخاص أننا قمنا بعمل قسم خاص وعيادة خاصة للكشف عن الجنين داخل رحم الأم للأمهات حاملي المرض والتي أصيبوا من قبل بأطفال عندهم هذا المرض. وفعلا قمنا بعمل أكثر من 100 حالة لكشف على الجنين prenatal diagnosis of thalassemia in our hospital and in our lab in the preventive department of the hospital and وقد نشر ذلك دوليا وعالميا. السادة الحضور، نحن نجتمع اليوم في اليوم العالمي لأنيميا البحر المتوسط لمناقشة أحدث الطرق في العلاج ومنع انتشار المرض ومشاركة العلماء المصريين ونخبة من كبار العلماء الدوليين في هذا المجال ليقدموا لنا علمهم وخبراتهم في مجال العلاج في الخلايا الجذعية والعلاج الجيني والحديث في طب الجنين وإنجاب طفل خالي من المرض وكيفية الشفاء والتغلب على مضاعفات المرض، وذلك من خلال الجلسات العديدة التي يقدمها المؤتمر في هذه المجالات. وسيقدم كذلك المؤتمر التجربة المصرية الناجحة لإيجاد الطفل سليم ومتوافق مع أخيه المريض من خلال البرينيتال دايجنوزيس. قدرنا إن احنا we could have baby, we could have cord blood from non-affected fetus to his brother, and we did a stem cell transplantation from the cord blood for the affected child, and now he is alright. بفضل الأستاذ الدكتور علاء حداد قام بعمل زرع النخاع. السادة الحضور، أتمنى أن تستفيد جميعا من العلم والخبرة التي تقدم من خلال هذا المؤتمر، وأن يكون هناك تواصل مستمر بين الخبرات المصرية والخبرات العالمية حتى يكون اليد الأمينة التي ترعى مرضانا وتقدم لهم الجديد والأمل في الشفاء. وأخيرا نقدم الشكر والامتنان العميق للشركات التي ساهمت في إقامة هذا المؤتمر ولولا دعمهم لما كان هذا المؤتمر، وعلى رأسهم شركة نوفارس، شركة فارمكس، شركة باير، كلين لاب، مينا فار، سبكترا، لبابو، شركة بيبي لاب، داياميد والشركات الأخرى. وتسمحوا لي أن أقدم كلمة لضيوفنا الأعزاء القادمين من الخارج. Our dear distinguished guests, Professor Faulkner from Italy, Dr. Farah Sher from United Kingdom, Dr. Andrew from United Kingdom, Dr. Kiwan from Kuwait, but originally I think he is from Ghana. On behalf of Dr. Oriyu from UNESCO, on behalf of the organizing committee, I would like to thank you all for accepting our invitation to participate in our conference and to share with us your experience and valuable knowledge in the domain of thalassemia, the disease which affects thousands of our dear kids. Dear our distinguished guests, I am sure that we will exchange our knowledge and experience, which will have its positive impact on our patients. I hope that you will enjoy your stay in Cairo, looking to the Nile from this place and in any place over the sea shore and the Nile shore and the civilization of our Egyptian. And Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very proud and honored to present our dear Dean of the Faculty of Medicine, the most ancient Faculty of Medicine in the Middle East. It is more than 170 years established. Professor Dr. Hussein Khairi, our Dean. Actually, we thank him very much because he has no time, though he has just take off some half an hour to come and present and attend our conference. Please, Professor Dr. Khairi.
Bismillahirrahmanirrahim. Professor Dr. Amin Bishrawi, thank you very much for this invitation. Well, I'd just like to add that our institute is 186-year-old now. It's not just 170, but 186 year. We're all very proud to belong to the institute. وطبعا among the jewels in the institute, the pediatric department is very distinctive in all the activities. It's been pioneer in so many things. Among that is the super specialization that is well apparent today in the conference that has been held for over 15 years, as I gather, for 14 years. Because I'm anticipating the future next year, inshallah. But it's been held for so long, where it's very specialized. Obviously, ever since I've been in the medical field, I've known Professor Dr. Amin Bishrawi and Dr. Lemis Rajab and Professor Lemis Rajab as they both dedicated their career to the hematology specialty and more than that to the thalassemia problem that I gather now is really common in our population. I'm happy to be with you this year. I've been here last year. I hope you have a fruitful day. Very nice meeting, inshallah.
Thank you all. And now we are going to start the best session. Please, the chairperson, come here, please.
Thalassemia, and I'm going to be talking today about outcomes with Xjade, and mainly focusing on some case presentations around patients and the challenges they have with taking Xjade, and also how monitoring will help improve patient outcomes. So the challenges around taking Xjade are adherence, and adherence is a universal problem for all medications and for all conditions. Our thalassemia patients are not alone in struggling with having to take daily medication. And the challenge for our patients is that they don't feel an immediate improvement from taking the medicine, and nor do their symptoms develop immediately or resolve immediately. For example, an antiarrhythmic will stop a palpitation. An antihypertensive medication may reduce your headache. But our thalassemia patients don't notice any advantages from taking their medication on the day that they take their medication. But they're highly likely to have side effects, and the side effects from the medication can be quite significant. Can everyone hear me?
Yes.
So this is a study that was done on patients who take statins, which are cholesterol-lowering agents. And what they did around this medication was to give patients some extended care or routine care. And the extended care was mainly focused around education and understanding for why the patient needed to take their medication. And the patients were given a personalised risk factor passport, which basically told them what their risk was of a high cholesterol, what the consequences of those actions. Do you want to use this one? This one. Can everyone hear me?
It's better.
Sorry. Okay. So in this study, basically, there were 201 patients who were enrolled into the study. Half got routine care, which was just they were prescribed the statin and told to take it, without any education or discussion around what the needs of the medication were. And the other half got extended care, which involved a risk factor passport, as well as education around lipids, the consequences of having high lipids, and how to optimize and reduce the risk of having myocardial infarction. The patients who were given the extended care had a significantly reduced anxiety, and their overall cholesterol levels were lower in that population. And education is absolutely critical to adherence to therapy. So I want everyone to think about one time in your life when your compliance to your whatever medication it is that you take was bad, and why, and one time when it was good, and why. Anyone want to volunteer an answer? In general, the main reasons why compliance is bad is when you don't know why you're taking the medication, or the medication is too complex, or there's significant side effects. And compliance is generally good when you know why you're taking the medicine and you see a perceived benefit from taking that medication. So in the UK at the moment, compliance with vitamin D therapy is very good because everyone gets cramps when they don't take it, so they feel an immediate benefit because everybody in the UK at the moment is vitamin D deficient. And this is a really important study because it shows us that Professor Piga and Professor Gabuti very early on in the 1990s recognised that compliance to Desral infusions was absolutely critical to patient survival. And people who were taking their Desral medication did extremely well, and people who didn't, unfortunately, died. So, I'm afraid this is very interactive. I will be expecting some answers from everyone. Okay, so what do you think are the key relationships needed to support adherence to complicated treatments that are associated with significant side effects, drugs like Xjade, for example? So who are the key players? Okay, so doctors and nurses, obviously, I think we play a really important role in getting patients to do their treatment. And so we're key players, but who else are key players? The family, absolutely. The family are really important, as well as the partners, so the husband or the wife, the children. Some of my patients who now have children only take their Xjade because their children are reminding them to do their treatment. And the support of a good clinical psychologist is absolutely critical in patients where there are real challenges for adherence. So if your patients have real issues around how they take the medication, and working with a clinical psychologist can help resolve some of those problems. And what are the characteristics of a good clinician-patient relationship? What makes a relationship between a doctor and a patient a good relationship that supports adherence? Trust, absolutely. So mutual trust is absolutely critical. You have to, as a patient, trust the doctor is telling you the right thing, and the doctor has to trust that the patient is not going to lie to them about their treatment. And it's a two-way relationship. And the other thing I think that's really important is that we should not judge our patients. If they have challenges with their treatment, it's really important that they're given the freedom to explain what those challenges are. They're not being disloyal to you by not taking the medication you've told them to take. So we should not judge them, because none of us, thankfully, or very few of us, have to take XJ or any other ion chelation therapy every single day of our lives. We don't have to do it. So we should not judge them if they're struggling with their treatment. And how can communication be promoted? All of the above, or are there other things we can do to help communication? Some of my colleagues have been busy developing apps for the iPhone, which will help improve adherence. There are whole loads of technologies available that help patients do their treatment better. And we should be looking at exploring all of those, because modern care nowadays is very much electronic based. So patient-centered care is really important, because patients' perspectives to their illness and their treatment are really, really important. And patients' perceptions, in fact, are very different from the doctor's perceptions. We know that we're telling the patients to take their treatment because it's going to improve their survival, but the patient on a day-to-day basis actually has to deal with their disease and the complications from their disease, as well as the side effects of the drugs that we're prescribing them. And patient involvement is really important to a good patient-physician relationship, and really important to patient satisfaction with their outcomes. So, key areas that you should tackle with your patients around their treatment is what their health beliefs are. You know, who do they feel is in control of their treatment? My patients who do really well are the ones who feel that they are responsible for their treatment, not the ones who say the doctor's responsible for their treatment. So encouraging the patient to take ownership of their results and of their treatment is really critical to improving outcomes. Aloe vera is a bit of a joke. I'll tell you about it with a patient that I'm going to talk about at the end, and you'll all get it later. Illness perceptions, fear of outcomes. So if a patient's afraid that they're going to die, or actually develop something really unpleasant like diabetes, they may be more likely to do their treatment. And a defeatist attitude, I'm going to die anyway, and whatever I do isn't going to make a difference, that kind of an attitude is not going to help clinical outcomes in your patients. And this is one of the areas where good clinical psychology support is really important, because some people are half glass empty and other people are half glass full, but the psychologist can help neutralize some of the half glass empty people. So what information is needed from the patient? So what I do is I go right down into very minute details with my patients. How much are they taking? How often are they taking it? What time of the day are they taking it? How are they mixing their medication? And one of the things that I tend to ask my patients is not how many days in a week do you take your treatment. I actually say, how many days do you miss in a week? And you're more likely to get the truth out of your patients by asking them how many days they're actually missing. Obviously, the ferritin is really critical, so that's already there. But other important things are things like the transaminases. One of the cases I'm going to show you, most of the work was actually based on what the patient's transaminases was doing. And also the creatinine and the urea are very, very important, particularly with XJ treatment, as well as the liver ions. So trending the results rather than looking at individual results is really important for all of these things. And drug-specific reasons, side effects of the drugs are really important to be questioned about directly. So if you're getting diarrhea, how often are you getting it? What time of the day is it happening? Because if the patient's getting diarrhea on their way to work and they're taking XJ first thing in the morning, it would actually make more sense to make them take their XJ in the evening so that they get diarrhea when they're at home and they're in a place where they can deal with it. So, our first patient. This is a patient who came from India. She was a thalassemia major patient, previously treated with deferriprone monotherapy, and she came over to the UK on a highly skilled migrant program. So she came in to settle in the UK. We started her on XJ when she arrived. Her liver iron was really high. It was 43 milligrams per gram dry weight, as measured by a ferry scan. And virtually all the MRI results I'll be showing you are ferry scan MRI results. So we know that they're very, very accurate liver iron assessments. She did really well with 40 milligrams per kilogram per day of XJ. And as you can see, over about 7 to 8 months, her liver iron went down to 27 and then went down to 15.6. And I was very, very pleased with how she was doing with her treatment. However, something happened. So, what happens next? So, I want people to take an option. You can do a show of hands if nobody wants to talk. Patient liver iron continues to fall. Who thinks that happened? Nobody? Good. I'm glad we're all cynical. Patient's liver iron stabilizes. No? Okay. Patient's liver iron rises? Yeah. That's why I'm showing you the case history. So, her liver iron rose up to 28 over about 9-10 months. And she basically lost her routine, daily, regular reminder for her medication. She lost her job, she wasn't going to work, she lost all routine around her lifestyle. And that really caused a problem for her. And I had very serious words with her around lifestyle and around how to improve her outcomes. And also, I think she was quite shocked at that significant change in the liver iron. She didn't expect it to have gone up quite that quickly. And following the conversation, this is her most recent liver iron, and it's now 10.1. And she's done a really fantastic job in getting her iron burden down again. And it is all around building a routine. It's easier for patients to do Desral because there is a routine and a ceremony around how they do it. Every evening they've got to mix up their Desral. If they don't mix it up, they know they've done something wrong or they've forgotten to do something. XJ, because it's oral, it's very easy to forget. And if you don't have a good routine around your XJ, you will forget to do your treatment and therefore get high liver irons when you don't want them. So this is another thalassemia major patient of mine who's on 40 milligrams per kilogram per day of XJ. And the question is, what on earth is happening here? They're on a really good dose of XJ. They tell me that they are taking it every day, but I don't believe them. So questions are, patient admits to not taking medication, patient denies not taking medication, doctor increases the dose on chelation as it's not working even at 40 milligrams per kilogram per day, doctor works out treatment plan with patient and leaves the dose the same, options 1 and 4, and options 2 and 3. So who would choose option 1? Option 2? Option number 3? Okay, nobody chose that. Number 4, doctor works out treatment plan with patient, leaves the dose the same. Okay, good few. And option number 5, which is option number 1 and 4. Some more people. Yeah? And option number 2 and 3. Anyone want to do 2 and 3? No. Okay, so the right answer is actually option number 1 and 4, which is option number 5 in total. And the patient was having real challenges with doing their treatment. And they weren't taking their XJ because they were getting nausea and vomiting every time they took it. And how did we resolve that problem? Well, basically, the problem was really quite easily resolved. So basically, I told the patient, take your XJ with food, don't do it on an empty stomach. And that really does help with nausea and vomiting side effects. And the other thing is something that one of my patients told me. They said, if you mix it in tepid water, that's lukewarm water, the tablets dissolve better and you do not get lumpy, gritty bits in the XJ. And it's the lumpy and gritty bits that actually make patients feel sick. So I actually advise this patient to take it in tepid water, wait 20 minutes for the tablet to dissolve in the lukewarm water, make sure it's a nice fine powder, When you drink it, add more water to it, and then drink it down. And we started again with XJ at a low dose, 250 milligrams, to get them used to doing it that way, and then we built them up to the 40 milligram per kilogram per day dose. And this patient had a really excellent response over a year of just small modifications in how to take your medication. And we only got this information because we went into the detail about how often, how much are you missing. All of those things were required to help give this sort of advice back to the patient. We're into the aloe vera story now. So patient number 3. This is a young woman who works as a trainee nurse, and she was in training at the time. She just started working shift patterns. It was her first year of nursing duty, and she was really struggling. And what you can see here is that her serum ferritin was jumping up and down between 6 and 10,000, but her transaminases, her ALT, this is the ALT side of the graph, her ALT was persistently rising over this period of time. She did a glucose tolerance test, and the glucose tolerance test was borderline diabetic. This young lady has serious problems within her lifestyle, and I told her, if you don't fix this, you will become diabetic within 6 months. Her glucose tolerance test was that bad. She was completely petrified of becoming diabetic. And this goes back to the issues around health beliefs and defeatist and positive attitudes. And she said to me, I will not become diabetic, I am not going to do a portacath, and I promise you I will make the XJ work. So I said, okay, I'll give you 6 months. And she said, I'll show you, Dr. Shah, and she showed me. This is her ALT and her serum ferritin not post aloe vera, but post improved compliance. She actually is a complete believer that taking aloe vera juice has helped cure her iron overload. I reckon it's definitely XJ. Anyway, we had to work out the issues around how she was doing her XJ. Because she's working shift patterns, including days and nights and lates as a nurse, my advice to her was to take it whenever she goes to bed and to not worry about the time of day, but to make sure that whenever she is going to bed, she takes her XJ on that time. And she was also another patient who was having problems with lumpy bits in her XJ, and again she started mixing it in warm water. And this is an absolutely fantastic result because her FerriScan MRI did this. She went within 9 months from a liver iron of 43 down to 9.9, and that is, so she avoided the diabetes and the portacath, and then her liver iron over the next few years has remained extremely good at around 2.7 milligrams per gram dry weight. And this is purely from changing the time of her medication and giving her a bit more of a routine around her therapy. So I think XJ has got really significant advantages for our patients. It's oral, it's once daily, it is an easy treatment to take, and it's easy to build that into your lifestyle. But the side effects limit the adherence, and the side effects are things that we really do need to work with our patients on helping resolve. And adherence to XJ is actually critical to good clinical outcomes for our patients. So working that detail into the patient's lifestyle is really important. And it's our duty really as healthcare providers to help find solutions to the challenges that the patient has. And it is again really important to individualise the regime to the patient so that it works for that patient as an individual. We cannot follow the blanket rule of half an hour before food, empty stomach for every single patient. XJ cannot fit into everyone's lifestyle in that way. We have to work out a regime that works for individual patients. And I think that's the most important thing that we can do for our patients as healthcare providers. So multidisciplinary care is really important in improving patient outcomes, particularly around adherence to chelation therapy. And it's really important that we educate our patients, we help them develop behavioural skills, that's lifestyle modification to fit in adherence, and we teach them self-management strategies. If they've got a challenge, They need to be able to find a solution for that, and if they can't, they need to be able to ask us to help. And often using rewards and social support is really, really helpful for patients. So I just want to say thank you all for inviting me.
Thank you very much, Dr. Farooq, for this very interesting presentation. Shall we have the questions now or at the end of the session? Yes. Shall we gather the questions at the end? Thank you very much for this practical and interesting presentation. I have the honor now to introduce our Egyptian godmother of pediatric hematology, Professor Amal Bishlawi. The talk of Professor Bishlawi is on improved survival and quality of life in thalassemia. Before starting, I just have a small request to the audience. Would you please put your mobile phones on the silent or vibration mode? Thank you.
Thank you very much, Dr. Alamis, for your introduction. Eminent chairpersons, Professor Dr. Alamis, Professor Dr. Doreen, Professor Dr. Mona Tegi, dear audience, I have the pleasure to stand here and talk with you about the improved survival and the quality of life in thalassemia patients. The outlines of my talk will be on overload, this is the key point, morbidity and mortality in thalassemia, what improved the survival and the quality of life in thalassemia, and our conclusion. All of us know that the cornerstone of treatment of thalassemia are red cell transfusion and iron chelation. The combination of transfusion and chelation therapy has dramatically extended the life expectancy of thalassemia patients. And this is showing you the area of deformable production, where the survival of the patients remarkably improved from 69, the year of 69, up to the area 85 and 97, where iron chelation, which is this is existed at that time. Meaning that chelation therapy is very important and can really affect the survival of these patients. So this fluoxamine started by the 1970. It is well established on survival of these patients. Inconvenient, but the inconvenient mode of administration renders compliance is very difficult, being given subcutaneously over 8 to 10 hours, 5 to 7 days per week. Besides, acidity and visual toxicity, loss of friction, and susceptibility to infection. Actually, there's a huge problem and endless suffering, as you see, with all putting subcutaneous needles, carrying so on. So, when the patient is only taking transfusion or is badly compliant to chelation therapy, is receiving one unit of blood of 200 milligram iron will be introduced to his body. This iron will give 0.4 milligram iron per kilogram body weight per day, beside the absorption from the intestine, which mounts up to 4 milligram per day. This all will give an iron overload for these patients in their body, especially if there is bad compliance, then there will be an iron overload. What's behind this iron overload? The non-transfusion bound iron will be increased, will be given the bile plasma iron. This non-transfusion bound iron will be present in the plasma, giving out the bile plasma iron, which is Radix active, and which can be chelated by iron chelators, and this as well is capable of permitting into organs and inducing tissue and iron overload. This the biplasma ion, when it's sustained inside the organs, it will compromise the function of these organs. Once the body has accumulated 12 to 24 grams of iron, the significant clinical manifestations of iron toxicity can be expected. This is showing you as well the mechanisms and results of iron toxicity, pathological forms of iron, non-transferable bound iron, the biplasma ion. This goes on the molecular level, destruction and enhancement in the function and depression of the function of different cells. This is showing you the iron toxicity results from another pathological form of iron, which is hemosiderin, which can affect well the liver cells. And this is the end result. Iron toxicity results in gross tissue damage in the liver, in the heart, and in the endocrine system. This is the molecular level, the reactive oxygen species, which can cause destruction to the mitochondria in the liver. And this is showing you the end result, iron overload and reactive oxygen species stress, that in mitochondrial damage. Iron toxicity can occur as early as second year of life in beta thalassemia patients who are regularly transfused and who are not well chelated. There is progressive dysfunction of the heart, liver, and endocrine glands. Growth retardation, delayed onset of puberty, and this is well known and documented in patients who are not receiving transfusion without chelation. For the morbidity and mortality of thalassemia, these are shown, this diagram or cartoon showing you the different system which is affected with the iron overload, with the pituitary giving impairment of growth, heart cardiomyopathy, the liver, hepatic cirrhosis, the pancreas, diabetes, and the gonads, hypogonadism, and infertility. This showing you the complications of beta thalassemia according to the age. This is cardiac cirrhosis, which liver cirrhosis can occur early in this area, and as well here we have the endocrine affections, the endocrine affection, and this is from after in the second decade we can have cardiac problems, which is apparent in this area, and the cardiac problem can more increase with the increase in taking iron overload and taking blood transfusion without chelation, together with the impairment of the endocrine glands. Cardiac disease, which is actually the main and the actual mortality and behind of morbidity of these patients, it remains the commonest cause of death in thalassemia. Transfusion iron overload is the main cause. As you see, patients poorly compliant to chelation therapy, serum ferritin levels of above 2,500 micrograms per liter. The cardiac arrhythmia, this can cause cardiac arrhythmia, cardiac failure, and sudden death can occur in a previously well patient. And sometimes you can see and can find sudden cardiac manifestations in these patients. Cardiac stenosis can be found in children as young as 8 years if he is not well chelated. This is showing you the high risk for heart disease among these patients. Patients on desfluroxamine found that desfluroxamine does not protect the heart completely from the affection of iron overload. Males actually are more affected than females. The high ferritin, as I previously saw, and there is something which is new but not very new, the T2 star of the cardiac magnetic resonance of this heart, which is below 20 milliseconds. The normal, it should be above 20 milliseconds. If it is below 20 milliseconds, this is denoting there is marked cardiac stenosis. As well, the second important organ to be affected is the liver complications. This is common in thalassemia majors, and there is different contributing factors. Iron toxicity, this is actually the first one. The viral infections, viral hepatitis, all of us know how much hepatitis C can affect these patients. Drug toxicity, this may be a cause, and biliary disease. This is shown you by the R2 or MRI of the liver, showing this bright area of the liver which is full of iron, or liver iron concentration is remarkably increased in this area. And this is showing you how much MRI can give us an idea about the iron deposition in the liver of these patients. As well, MRI has got a very important role in diagnosis and in finding the cardiac siderosis among these patients. It has got many advantages. It is rapidly assessed iron content in the septum of the heart. Iron levels can be quantified reproducibly. Functional parameters can be examined concurrently. And as well, we can check the LIC, liver iron concentration, together when we are checking the heart siderosis. What about the cause of death among these patients? Actually, heart disease, this is in different areas of the world, in Italy, Hong Kong, Cyprus, and in Egypt. This is a study that has been done by Dr. Galina Mukhtar in Shams University. Actually, heart disease stands is very important among these patients, and as you see, that heart disease is the main of all causing death among these patients. Infection as well can be a cause. Bone marrow transplantation, the complication of bone marrow transplantation, and as you see, we have only one column from the bone marrow transplantation from Hong Kong. Seems that the complication of bone marrow seems to be less now. Accidents, liver, and other areas. And this is the affection in Egypt, where heart affection is liver affection is very common due to hepatitis C. For the cardiac to start on this fluoxamine, this is showing you that this fluoxamine does not protect the heart from iron overload. This is showing you that 58 to 52% of the patients has got the cardiac to start is less than 8 milliseconds, which is meaning severe cardiac siderosis. And 13% of this is this 35% of these patients has got only within the normal limits, and this as well still there is cardiac siderosis in these patients, and showing you that this fluoxamine, we cannot depend on it for completely removal of the iron from the heart. This is the Egyptian study which has been done by Dr. Galina Mukhtar and has been published, that there is significantly higher ventricular dysfunction and hypogonadism in patients usually using this fluoxamine. What improves the survival and the quality of life in thalassemics? There is different causes. Actually, the evolution of the oral anticoagulators like difluron and Exjade, better adherence to iron chelation. This is very important for the outcome of morbidity and mortality in these patients. Good adherence gives a good health and more survival in these patients. The era of non-invasive diagnostic facilities for cardiac and hepatic iron overload, cardiac magnetic resonance to start, and this is for the heart, and this is R2 for the liver. This is very important. This is non-invasive and give us an idea on the cardiac siderosis and deposition of iron in the liver and the heart, which is actually the main cause of morbidity and mortality. As well, better management and the availability of treatment for other thalassemia complications like hepatitis C, now it is usually treated, endocrine disorders by hormone replacement therapy, and in diabetes, which can be now well controlled. This is a study which has been done by Dr. John Porter and me and Dr. Michel, where talking about the challenge of adherence and persistence with iron chelation therapy, which actually is very important for the outcome and health of these patients. For the DIFA oral anticoagulation, this oral anticoagulation, the first one, difluron, which is the first known oral anticoagulator, is taken 3 times per day, because half-life is short, 2 to 3 hours, approved to the treatment of iron overload in adult and pediatric patients with beta thalassemia major, and is often used in combination with this fluoxamine to give a better result, because as I said, the half-life is very short, so they have to continue to give another, which is this fluoxamine, to decrease the level of the labile plasma iron, which is present in the plasma and causes much of the morbidity affecting these patients. This is showing you that this fluoxamine alone, this is only decrease of the labile plasma iron when the patient is taking this during the injection of this fluoxamine. And this is showing you when it's taking difluron, only decreases during difluron taking when it is inside the circulation. And this is showing you the advantage of taking difluron with this fluoxamine, showing that there is complementary that decreases and then completed those decreased labile plasma iron by this fluoxamine in the rest of the hours of the day. It is a tenfold tenfold improvement in cardiac outcomes in severely iron overloaded patients. Switching with this fluoxamine to difluron has been reported. This is likely to be due to improved removal of myocardial iron and left ventricular function improvement. Improved actually adherence with oral compared with subcutaneous therapy may also play a role, and I think that oral iron chelation is very important to improve the compliance of these patients. If we next oral iron, more recent oral iron chelator, FJ or difluroxime, the more recent oral chelator approved for the treatment of transfusional iron overload in various transfusion-dependent anemias, most of the anemias, myelodysplastic syndrome, pleural cell aplasia, and all other forms of anemia and iron overload, has a long half-life, and this is a big advantage of difluroxime. It stays in the plasma for 8 to 16 hours. It only needs to be taken once orally, only once daily. This is a next very important advantage. And this is showing you over 24 hours chelation coverage is achieved in adult patients following multiple FJ dosing. Even when the dosage is only 10 milligram, is also as well present in the circulation. Increasing the dose, still it is present in circulation, and showing you that it is present in the circulation over the 24 hours, so it can take the labile plasma and can be suppressed most of the time due to the presence of FJ in the plasma, suppressing these noxious labile plasma ion. And this is showing you how much the patients are very satisfied and very convenient with the use of this fluoxamine. This is showing you a baseline, they are equal, and then after 4 weeks, these patients are more satisfied. Over this study, which was over 1 year, the patient was very satisfied. And if we come to the convenience of these patients, actually they are very much convenient all over the study, as you see, till the end of the study, until they are using up till now in their chelation regimen. This is showing you the compliance to chelation therapy with difluroxime and difluroxamine in Egyptian thalassemia patients. If you look to this fluoxamine, you find that these patients actually are non-compliant. They're only taking it when there is complications in this area. But if you look to this fluoxamine, this 85 or 86% nearly of the patients are very compliant to this fluoxamine or FJ. This is the health-related quality of life, which has been studied by Dr. Jim Porter. This is showing you, this is an actually SF36 domain score. This is showing the health-related quality of life, studying different and asking about different parameters in the patient, showing how much health-related quality of life in these patients are affected. This shown in physical functioning, this is at the start, this line, and this is after 1 year of the treatment, and they show only also the same results with the raw physical, with body weight, with general health, with vitality of these patients, and with the social functioning and the emotional and mental health. Actually, most of the parameters actually are positive after taking this difluroxime or FJ. This is showing you the effect of difluroxime on decreasing the liver iron concentration with up to 5 years of treatment in patients with beta thalassemia. This is showing you at the baseline and it's showing you after 1 year, and this is after 5 years. Actually, it is very significant, even after 1 year, and it's more after 5 years. This can be seen even after 5 years or after 4 years in 2 different studies. This is showing you the improvement even of the liver pathology with at least 3 years of this Fluoroxyrex treatment. This is showing you that improvement to 2 years. Overall, this is a number of the patients, 219. Liver iron concentration response success, which is really is a good number. And this is showing you that some of the patient and pathology cannot be changed. But overall, 83% of patients showed stabilization or improvement in their liver fibrosis staging. And those showing you as well, the reduction in iron staining demonstrates a defluorescence efficacy after 1 year in the liver. This is showing this is the dysphorexamine, and this is the dysphorexamine or FJ, showing you the decrease in the iron in the liver, as you see, by a dosage of 30 milligrams per kilogram body weight. And even this patient has got hepatitis C affection, and though there is decrease or minimizing of the liver iron concentration in this patient. Actually, they are nearly the same like dysphorexamine, by the same level by decreasing the liver iron concentration. What about the heart? This is showing the effect of this Fluoroxyrex on cardiac restart were to use in patients with beta thalassemia. Actually, this is all the patients showing the improvement in the cardiac restart. This is the baseline with this is the whole patients, 11.2 increases up to 15.7, and increase meaning improvement in the cardiac states and decrease in the cardiac siderosis. And this is a patient with very severe cardiac siderosis, which is 7.3 milliseconds. It also improves to 9.5 millisecond. And actually, we have got a patient, but actually there is no time to present to you, who started, this is our patient, now it is 21 milliseconds for due to start by using and completing using of this Fluoroxyrex or FJ. To prevent thalassemia morbidity, what we do? We have to attain and maintain annual average serum ferritin between 500 and 1500 microgram per liter. Liver iron concentration should be less than 7 milligram per gram body weight. Cardiac to start should be more than 20 milliseconds. But take care that in heavily iron-loaded patients attain these levels attained after several years of consistent chelation, because many of the patients start chelation so late in this case, so they take a longer time to decrease down or lower down the amount of iron which is invading the tissues. So, our conclusion that survival and the quality of life of thalassemia patients remarkably improved after the era of oral iron chelators and the non-invasive facilities, the cardiomagnetic resonance to start and R2 for the liver to monitor cardiac and hepatic iron load. Improvement in the management of other thalassemia complications also plays a role. Still, hepatitis C is a challenging complication in developing countries. And thank you all for attention.
Thank you very much, our dear eminent professor, Dr. Amal Bishlawi. Now I have the honor to introduce our dear guest, Dr. Shah from the United Kingdom. This is the second book update on clinical trial in thalassemia.
Thank you for, I'm going to talk about clinical trials and just give an update in thalassemia. Now, we have a challenge in that there's many clinical trials in thalassemia, not just iron chelation, but also trials around bone density and trials around other health problems in thalassemics, and I won't be able to cover all of those. If you do a search on iron and chelation in PubMed since 1960, you see that there's been a dramatic increase of publications per annum, going up to over 300 publications per annum most recently. The first clinical trials in patients in thalassemia were chemical properties on iron chelation drugs, particularly around Desfrau. In the 1970s and early 1980s, it was randomized trials on Desfrau intramuscularly, and then intravenous infusions, and then deferriprone came into clinical being in the early 1990s, and clinical trials from deferriprone started to be published. And then the deferocyrox or XJ preclinical studies started to be published in the early 2000s. So there's been many, many publications over the last 40 years or so on iron chelation in thalassemia. And this is roughly the kind of areas that those trials cover: beta thalassemia, sickle cell disease, myelodysplastic syndromes, and rare anemias. And there's been lots of really interesting publications which I strongly encourage everyone to read, which are based around the changes that chelating patients with myelodysplasia has on patients' red cell indices. And I think that's all really positive use of iron chelation therapy in that group of patients. There's also been publications on non-transfusional iron overload, improvements in hematopoiesis, neurological distribution. There's been some really good publications using deferriprone in Friedreich's ataxia and other neurodegenerative conditions. Again, very interesting use of iron chelation. There's also been some interesting publications on use in iron chelation in people with myocardial infarction. So I think iron chelation is no longer just restricted to thalassemia patients. Just to put into context clinical trials in thalassemia, the first patients that were described by Thomas Cooley in 1925 were 5 children who had all of the classical thalassemic problems that we see nowadays in new diagnosis thalassemia patients. And this is a survival trial, really, if you look at it, because 3 out of the 5 patients died. The 5th was still alive post-splenectomy, and splenectomy in that patient was an experimental treatment and was very much a trial for that patient. The first trial on blood transfusion in thalassemia patients was again done by Cooley, and they actually gave one of the patients a mixture of spleen and red bone marrow combined with hydrochloric acid. This is copied ad verbatim from the original paper. One transfusion caused a slight transient blood change, and urine examination showed hemolysis, and a more recent transfusion was followed by a better blood picture and less hemolysis. So clinical trials in thalassemia have been present from the very, very beginning of the first description of patients with thalassemia. But actually trials, so-called, in transfusion have been around since 1665, when the first patient was transfused the blood of a baby cow, a calf, into a man who'd fallen into a frenzy. The patient died, of course, because nobody knew about animal-to-blood human transfusions. And in fact, animal-to-human transfusions, which were being attempted, were actually banned in 1678. Human-to-human transfusions were first tried by James Blundell in the Victorian era, and 5 out of 10 of those were successful. And basically what he did was that he took the blood of the husband and transfused it to the wife in the management of postpartum hemorrhage. So that was clinical trials in blood transfusion. Now on to something slightly more serious. The first really important clinical trials in thalassemia were published in 1964 when Woolman showed improved survival and improved quality of life in thalassemia children who were receiving regular blood transfusions. And Piamelli thought that maybe if you hypertransfuse children, i.e. keep their hemoglobin at a good level, you'll get a better outcome. And in fact, he did show that there was less hepatosplenomegaly and less cardiac problems in patients who were on high-frequency regimes with transfusion. And all of our transfusion practice nowadays is based very much on what Piamelli published. So, The results of the original transfusion trials showed improved outcome, improved growth, better quality of life, and reduced extramedullary hematopoiesis, which is clearly the key aim for all thalassemia patients. But transfusion came at a cost. Patients were developing endocrinopathies and they were dying from heart failure. Cooley, one of his patients, actually received a splenectomy, and the splenectomy clinical trials, the first one was actually published in 1935 by Pemberthy and Cooley, and that became a routine treatment for all patients up until the 1970s. And I think it's really important to just sort of think about how our predecessors who looked after patients with thalassemia have had such a massive impact on what we do with our thalassemia patients. They've completely changed the management of the disease from a fatal to a disease that is now a chronic condition. So the splenectomy trials showed, of course, improved outcome and survival. However, they also showed there was an increased risk of dying from infection, and also in 1935 they showed there was an increased risk of thrombosis. And this is stuff that we now, from the Optimal Care study, have got much more rigorous data on. But the original data was described in 1935 by Pemberthy and Cooley. So Desral first came into being in the 1960s, and it was designed to treat acute iron overload. And many groups in the 1960s started to use Desral to see whether they could get rid of transfusional iron overload. But pessimism was rife because people were not doing very well with Desral. And the first and only ever conducted placebo-controlled randomized trial on Desral was published in 1974 by Barry et al., and this completely changed management of all patients. So in the Barry trial, 500 milligrams of Desral was given 6 days a week IM, and 2 grams IV with transfusion to control arm which had no Desral. We're talking about tiny doses of Desral. However, despite those tiny doses, there was a significant fall in liver iron in the people who were in the treatment arm, and less hepatic fibrosis in the treatment arm, and the patients who were in the placebo arm died. And follow-up data in 1981 showed 6 out of 10 people in the control arm died, and only 1 out of 10 in the treatment arm had died. And this is the only placebo-controlled randomized trial ever done, actually, in thalassemia major. So these are the Desral trials. There was many studies done by a whole variety of people which have actually impacted on outcome in patients. And the most important out of these, I think, are the data using high-dose Desral, and also the use of continuous Desral infusions published by Cohen et al. So much work was done with Desral, and the consequences for the patients were really fantastic. Patient survival, Professor Bishlawi's already shown this graph, so I'm not going to dwell on it, but patient survival in patients receiving Desral, that is the cohort from the 1970s, became excellent, whereas the patients who did not receive Desral at an early age were the patients who were having bad clinical outcomes. So deferocyrox, as I've just shown in the very first graph, was the drug that's actually had a massive impact in increased publications on PubMed, on clinical trials. And the main reason for this has been is that deferocyrox has gone through a really intensive development program, which started in 1989, just over here, in its 1998, sorry, in its first phase 1 study, and has actually continued right up until 2013, when data from the Thalassemia study and data from Cordelia, and now hopefully data from the Hyperion study will be published. So we're talking almost 12-13 years worth of randomized trials which have been done to look at outcome and improvement of survival in patients with deferocyrox. And this is data just from the original licensing studies showing that if you give patients deferocyrox over a long period of time, this is 5 years, you have a very consistent and regular fall in the serum ferritin. And serum ferritin, as we know, reflects liver iron burden. The other important data from the clinical trials really has been the side effect profile with deferocyrox. And in general, what you can see is that the side effects are the worst in year 1, which is the dark blue column, and by year 5, the light blue column, most of the side effects have been resolved or settled, or ways have been found to manage those side effects. So the side effect profile for deferocyrops over 5 years is actually very good. And Professor Bishlawi again showed the 24-month data for the EPIC sub-study looking at cardiac iron loading. This is the 3-year data showing that in people who, this is all patients in green, cardiac T2 star improved consistently year on year. The severe category went from severe to mild, and patients who were in the mild to moderate category went from mild to moderate to no myocardial iron over a 3-year period. It's really important that both the studies from deferocyrops and also the studies from Descral and deferoprone have all shown us that taking cardiac iron out of patients is not a quick thing to do. It takes years, sometimes anywhere between 3 to 5 years to completely clear the heart of iron. This is data from the Cordelia study, and I think this study is really important because it does a head-to-head comparison of Exjade with Descral and looks at myocardial iron clearance in these patients. And the Cordelia study looked at 96 patients being given deferocyrops, compared them to 96 patients being given Descral, and the study went into an extension phase of a year. And the doses, the results of the Cordelia study, the original patient cohort were very, very similar. This is the deferocyrops cohort, that's the Descral cohort. Very similar T2 stars of the heart, very similar liver ions. Ferritins are again very similar, as is the ejection fraction, so there's no patient selection bias in that population. And in all patients, what you can see is that the cardiac T2 star improves, both with Descral and with deferocyrops. And the other important thing is that the lines are very, very close together. So the improvement is almost identical. And what you can see in patients with T2 stars of less than 10 is that, again, the drugs are almost identical, but there is a slight trend towards superiority with deferocyrops. So the Cordelia study has shown us that deferocyrops 40 milligrams per kilogram per day is as effective as Descral at 50 milligrams per kilogram per day in removing myocardial iron, with a trend towards superiority for deferocyrops. And I think the Cordelia study gives a lot of reassurance to a lot of clinicians that this is an effective treatment to use. The hyperiron study has just finished, so the patients are just going through their closeout studies. This is a study which looks at the rate of improvement in myocardial iron in patients with the worst cardiac T2 stars. People with T2 stars of less than 8 milliseconds were recruited into the study, and patients were given Descral at a dose of between 20 and 40 milligrams per kilogram per day on 5 days a week, and the deferocyrops 40 milligrams per kilogram per day, 7 days a week. I'm going to show you the result of one of my patients who was in the hyperiron study, but the data from the hyperiron study is not yet published in abstract form or in any other form. The Thalassemia study is a study that was, a lot of doctors here contributed to that study, along with Professor Ali Tahir and many clinicians who look after patients with thalassemia intermedia. The Thalassemia study basically looked at non-transfusion dependent iron overload, and again, this is probably the second randomized controlled trial in thalassemia patients, placebo-controlled randomized trial in thalassemia patients, although these are intermediate patients, so it was ethical to do this. And patients were randomized to deferocyrops or placebo, and at 2 different doses, 5 milligrams per kilogram per day and 10 milligrams per kilogram per day. And it was a 2-to-1 randomization, so 2 people got deferocyrops and 1 patient got placebo. And the results of the Thalassemia study show that the liver iron reduced significantly in patients who were receiving deferocyrops, whereas the patients who were receiving placebo gained iron. And the serum ferritin in people receiving deferocyrops, again, reduced significantly, and people receiving placebo had an increase in the serum ferritin. And this is the correlation between the liver iron concentration and the serum ferritin. So the Thalassemia study basically tells us that deferocyrox is effective at reducing liver iron in non-transfusion dependent thalassemia with a similar frequency of adverse effects compared to placebo. So the patients who were on placebo also got side effects, and the side effect profile was very similar. Now, deferriprone, there have been some really interesting publications on deferriprone recently. A lot of it is on neurodegenerative conditions, and a lot of it is on Friedreich's ataxia, etc. However, I think the most pivotal and most important deferriprone study is the one that was done by Tanner and Professor Pennell's group, showing the improvement in myocardial T2 star in patients on deferriprone as compared to desferrioxamine, similar to the Cordelia study. And again, with this study, this has impacted on clinical management, because we know that in patients who've got the worst myocardial T2 star, they do better with deferriprone in comparison to desferrioxamine. FSB0701, or now under Shire SPD0603, is a drug that's in clinical development. It's a deferrothiacin-based derivative and is a tridentate iron chelator. Renal toxicity is a real problem in this group of drugs, but this molecule underwent some modifications, and they've replaced the molecule with a hydroxyl group, which has meant that the renal toxicity is now non-existent. And the drug has been published as phase 1 and phase 2 clinical data, and the phase 1b data showed that the drug was safe to take, and it was well tolerated, and it also gave us some information about the pharmacokinetics. And essentially the drug is going to be used as a once daily or twice daily regime. And the phase 2 study was published, was presented at ASH last year, and essentially 51 patients were recruited into the phase 2 study. The phase 2 study is now being extended, and there's many more patients in it. But they were comparing in the original cohort of patients 2 doses, 14.5 and 29 milligrams per kilogram per day. And again, what they've shown is that there wasn't any significant serious adverse events with those 2 doses. The common adverse events were transaminitis, and the dose of 29 milligrams per kilogram per day is the dose that will maintain liver iron. It's not an iron-reducing dose, and the study has been extended to higher doses now to find the iron-reducing dose. Right, we're going to talk about my hyperiron patient, so some really positive data on a clinical patient here. This is a 27-year-old thalassemia major patient who arrived in the UK as a student in 2010 from India. He was unbelievably heavily iron overloaded at the time of presentation, with all of the classical skin iron deposition and other features of severe iron overload. He also had a large spleen with evidence of hypersplenism, and he had severe myocardial iron loading with a T2 star of 6.1 milliseconds, with a normal ejection fraction, and his liver iron by FerriScan was above 43. And he'd been chelated on deferriprone, the Indian formulation, for many, many years. He's very, very skinny, as often many thalassemia major patients are, and he was absolutely adamant he was not going to do desferal. So there was no discussion around him going on to combination therapy. So we then agreed to put him onto deferocyrox at a dose of 40 milligrams per kilogram per day. And his liver iron, a year later, on 40 milligrams per kilogram per day, was still 43 milligrams per kilogram per day, or above 43 milligrams per kilogram per day. However, his liver enzymes, the ALT, I really do like the ALT. It's a really, really useful thing to look at from the trend perspective. So his ALT, when he'd originally started in the UK, was around 100, and his ALT, the general trend, was downwards. So I basically said to him, don't worry, the iron is coming out. And clinically, he was improving. The skin iron deposition had improved significantly. So, what would you do? Increase the dose of deferocyrox? Hands? Check adherence to chelation therapy. Yes, lots of nods. Change to IV Desfrel because it's not working. Nobody? Change to Deferriprone? No? Reassure the patient and carry on. Yeah? I reassured the patient and carried on. And we then had the opportunity to enroll him into the hyperion study. So his ferritins were fluctuating between about 1,000 and just above 9,000. So he was enrolled in the hyperion study. He did not want to do Desfrel, but he agreed to do Desfrel via a portacat. And he then started on 40 milligrams per kilogram per day of Desfrel, IV, 5 days a week, 24 hours a day, and the ferrosirox, 40 milligrams per kilogram per day. And if you look at this graph, this is a trend of the serum ferritins from the start of the hyperion study down to the final closeout 2 years later on the hyperion study. And he only goes to a ferritin of about 8,500. So this is what happens to his transaminases. His trend continues downward, and his transaminases normalize, even though his ferritins are very high still. They're over 8,000. This is what happens to his liverine. And this is just the most beautiful graph I have ever seen, because you can see 3 consecutive above 43 milligram per kilogram per day, milligram per kilogram liverine values, and then you see this plummeting down. He was on the hyperion study from this point onwards. You see this plummeting down of his liverine. And that plummeting down is essentially when his liverine became measurable by Ferriscan. We have to recognize that Ferriscan can only measure up to 43. And probably, if you trend this line backwards, his liver iron was probably somewhere in the region of 80 or thereabouts when he actually started iron chelation therapy with the ferrosirox. And the limitations of the test are there, but the clinical response is remarkable. And from the point of view of the cardiac iron, his T2 star from initiation of study, 6.1 milliseconds, went to 8.9 milliseconds after 2 years. And this is despite really heavy hepatic iron loading. And one of the things that we know is that if you're very heavily hepatically iron loaded, the cardiac T2 star really doesn't improve very significantly with severe hepatic iron loading, because the liver iron is being removed and the cardiac iron follows as a secondary event. So that's the hyperion patient. I'm really looking forward to seeing what the data from the hyperion study shows. If my patient is anything like the general patients that were seen in the hyperion study, I think the results will be really, really exciting and may very well change the management that we currently use for patients with regards to combination therapy. Thank you.
Thank you very much, Chairperson. And good morning, ladies and gentlemen. Let me start by thanking Professor Amal for inviting me to participate in this landmark conference. And to say that I work in Kuwait, and I've been in Kuwait for almost 20 years now. But originally, I'm from Nigeria, not Ghana. I also want to congratulate Professor Amal for including sickle cell disease in this opening session of the conference. I know that when doctors who do thalassemia get together, they tend to forget about sickle cell disease. And I don't really know how many people in the audience look after sickle cell patients. Okay. But what I intend to do in the next 25 minutes to 30 minutes is to give an update on sickle cell disease, to highlight some of the important developments in the last decade or two, and to, again, highlight some of the very important concepts. Therefore, I'm going to spend some time on the pathophysiology, talk a little bit about the features and complications, and because of what we know about the variability of the disease, I'm going to talk about some of the modifiers of the phenotype, especially hemoglobin F, which we know, because from what we know about newborn babies who do not have sickle cell-related symptoms in the first 6 months, and we worked on that over the years to know that fetal hemoglobin is extremely important in modifying the phenotype. And that leads us to the use of hydroxyurea in the disease, which is, again, has been a game changer. And then we'll focus a little bit on stroke, talk about stem cell transplantation, and if time permits, I'll give 1 or 2 slides about our experience in Kuwait. Now, we are all familiar with the mutation in hemoglobin S, the beta-globin gene, in the 6th amino acid position where valine substitutes glutamic acid, with effects on the physicochemical properties of the molecule, especially the decreased solubility in the oxygenated medium where the hemoglobin S forms polymers. These polymers, of course, disturb the red cell membrane, and it goes through the cycles of sickling and unsickling until you have irreversibly sickled cells. And of course, the cells are rigid and they cause occlusion of the blood vessels. Now, up to the 90s, our understanding of the pathophysiology of sickle cell disease was limited essentially to the polymerization and the factors that promote polymerization. But it became clear, of course, with time, that sickle cell disease was in fact more of a chronic inflammatory disease, especially expressed as a vasculopathy with involvement of the vascular endothelium. And we now know that a lot of that is mediated through heme, free heme, that is released with hemolysis. And eventually, the central dogma of this is nitric oxide depletion. And nitric oxide is very important for maintaining vascular tone, smooth muscle tone, and with depletion there's vasoconstriction, and eventually you have hyperplasia of the intima, which leads to occlusion, and then there are other factors that contribute to the occlusion. But again, there are several factors that lead to the nitric oxide unavailability. First of all, when the aptoglobin, which initially takes up the free heme, is overwhelmed, then there's scavenging of nitric oxide to detoxify the free heme by producing methemoglobin. Now, the second thing that happens, of course, is that with hemolysis, there's a release of arginase, and arginase converts L-arginine, which is the precursor for nitric oxide, instead of going through the nitric oxide synthase to produce nitric oxide, it is diverted to form ornithine, which limits the availability of arginine for nitric oxide production. Now, the third thing that happens, of course, is that these xanthine oxidase and NADPH oxidase are upregulated in sickle cell disease following hemolysis, and those substances generate free oxygen radicals, which again deplete the nitric oxide availability. So those are the factors that eventually lead to nitric oxide depletion. Now, the other thing I would like you to take note of is that with hemolysis, of course, the other intracellular agent that is released is LDH, lactate dehydrogenase, which is then used as a marker for hemolysis and sickle cell disease. Okay, now, of course, we have the central problem of polymerization, and then we have, because of the hemolysis, we have nitric oxide scavenging. But again, that triggers so many other inflammatory processes. First of all, there's increased addition of molecules. There are all kinds of inflammatory cytokines that are released, and of course that again affects the white cells, which also adhere to the endothelium, with producing eventually the vaso-occlusion with ischemia, reperfusion, injury. On the other side here, exposure of the phosphatidylserine in the membrane activates the coagulation system, so that in effect, sickle cell disease is also a pro-coagulant state. Okay. Now, of course, there's also lipid oxidation, which affects the red cell membrane, makes it quite rigid. Therefore, there are so many things that are going on, you know.